Uh, yeah. All right. So I have a brave soul who would like to share how they got their way when they were little.
I can share.
Go ahead.
So my group was actually pretty similar. We all talked about, how we were younger, we did the typical like throwing tantrum and things like that to get your way. And now, like, we don't really necessarily ask our parents for a whole lot. If we do, it's something really serious, and our parents know that. So it's not really a matter of having to like fight for your way. But we also talked about how it's very situational. And we all were in agreement that we are definitely more on the violent side when it comes to the people that we're closest with, like our siblings, our significant others, sometimes your parents, if it comes down to it. But then, like, in a professional setting, never on the violent or aggressive side, always like super professional, to the point where people that we work with would even say that we're calm or like non-confrontational and things like that. So I thought that was interesting, just to talk about the difference in situation and how we can sometimes be more mean to the people that we're closest with, I guess, because we know that they love us and they're not going to leave us.
Yep, they're not going to throw you away. Yep, exactly. Thanks for sharing, Kelsey, and getting us kicked off. Who else?
Our conversation kind of led to, jumping off of the end of Kelsey's comment there, it was interesting to me because if I would have taken the SUS scale, I'm not even sure how to refer to it. Depending on if I was thinking about my family or if I was thinking about my work session, it would be different. But that made me think about like domestic violence kind of pieces, and how that can really play in, because I think about some really intense arguments with my husband, and my violence score could have gone up. Whereas I don't know that I care about anything enough in work that would bring me to that point, right? So that was just interesting to think through that.
Absolutely. And I think that's, you both brought up really good points, that we can have different modes at home with our family and our friends than we do at work, because there is this level of professionalism, and that persona of who we want to be at work is not necessarily our most authentic self. It's our most authentic work self, right? But our most authentic personal self is what our family members and friends are going to see. Absolutely. I always loved, go ahead.
Sorry, I was just going to say, going off of that, we also talked about, like, as females and like all the stigma now around being bossy or, and just kind of like the fear, and like sometimes we will do something. Like, for example, if I really want to go on a date night with my boyfriend and he's just like, oh no, we can't do that right now, there's a football game on or whatever. And I'm like, all right, well, I'm gonna go out with someone else then. Because like, I want to get dressed up, I want to go out. So I'll go out with one of my girlfriends, or like just kind of treat myself. And sometimes that could be taken as like throwing a tantrum or being too stubborn or something like that. Whereas also with society now, there's all this push for women empowerment and, kind of taking care of yourself and putting yourself first.
Great reflections. Thank you. A few years. Oh, go ahead, Kelly. Go ahead.
I was just going to say, I feel like at work, working one-on-one with my patients, I feel like I give so much to my patients, and then I'm on all the time, and it's like this energy sucking. So when I come home, I'm more aggressive or violent, I guess you would say, just because I'm tired though. It's not something from work to home. It's just, I feel like at work you have to put on a face sometimes, and it can be
more in your primal brain. You're more in your like basic hindbrain than you are in your frontal lobe. Yeah.
Right.
Yeah.
And then Cheryl also put in the chat, our group talked about how the continuum across work and home and how we adjust.
Definitely.
Kelsey said caregiver burnout. Yep.
Yeah, absolutely. Great. Yeah, I'll just leave you with this one that I thought was just so fascinating. From a few years ago, a trainee said that when she was little, she wanted a dog. And so she created a PowerPoint of all of the reasons that she researched why having a dog would be good for her, and presented it to her parents, who were unshockingly both engineers, because she learned that she needed to appease their ways of taking in information and dealing with conflict. So she had to present all the information. Now she's a psychologist, so she was well bred for that position in her life. But it just as an example, it all goes back to how we were built, how we were nurtured, how we were maybe not nurtured growing up. And as Kelsey brings up, kind of the societal push for different role adjustments and things of that nature in coming to conflict, right? I would say it's been, oh my God, it's been like 7 years now. I cried once at work in front of someone and I got reprimanded for it. I was basically told, like, you were too emotional. And I was like, I was being told to do something that no one should ever be told to do in the workplace. And I cried because I was so frustrated. And then later on, like I said, I was reprimanded for it. Now today, 7, 8 years later, that would have never happened, right? We've just even come a long way in acknowledging that people are able to emote. People can have reactions in just that short amount of time. So I am positive that we are moving in the right direction around people's psychological wellness and well-being, but we have a long way to go. And we have people who still have a lot to learn that are in management positions. And so we want you all to leave us in the LEN program being good leaders, but also being good managers and recognizing that if people need to emote, people need to emote, right? And how do you hold that time and space for them? And how do you handle that emotionality with them, but not for them, with them? So, all right, anything else in the chat box? Yes, Cheryl, nothing like a good PowerPoint. Yeah, I love it. And Kelly did it for a phone. Perfect, I love it. Awesome. Okay.
I will say my mother was laughing. My mother was here trying to help me with my kids as I was going through this. So when we went through the whole, what do you do as a child? She was just laughing her butt off in the background. So thank you for that entertainment with my mother today.
Yes. She could probably come up with many examples.
Too many.
Yeah. Oh, I love it. Great. Well, we've kind of already started using the terminology from the survey scale at the beginning, but there's this continuum of responding. And I feel like this text uses these as pretty extremes, like silence and violence are pretty extremes, but everybody is more, in the mean, in that 80% in the middle, right? But we want to work on yourself, and it's not hitting people in the sense of a violence, of a real physical hitting, but it's how do you use your words to make them cutting? How are you potentially being passive aggressive? And so silence and violence are kind of those extremes, but we can see in others and in ourselves where maybe we fall in the middle of this continuum. So I'm going to go through some examples, and maybe some things will stimulate your thinking. So in silence, you have this example of what they call masking. And this is really what I think about as passive aggressiveness. So it's understating what you truly mean. So my example is, oh yeah, that'll work like a charm. People love to wait 3 weeks to see the doctor, right? We hear this all the time. And a lot of these things I tend to hear more when it comes to blaming the system and blaming systems issues. And then we also have avoiding. So it's like, how do I just get rid of this sensitive issue out of my life? And just kind of changing the subject. Speaking of work ethic, did you see This Is Us last night? Right? Like, oh, how do I stay talking to you? But we're going to turn the corner here and adjust so that we're not talking about that heavy issue. Withdrawing. The worst example I've ever seen of this, and I will bring it up because it was a former LEN trainee who did not finish the program, pulling out of the conversation completely, hanging up and hitting the end button. Yep. You can understand why that person was not a finisher, not a graduate of the LEN program. But we see that, like, I can say now I've seen that. Somebody literally said, nope, this is a hard conversation. I'm not even going to let you know I'm hanging up. I'm just going to hang up. Right. But thinking through where these maybe not in their extremes happen, but how things get pushed off, right? Maybe something's come up multiple times, but it's like, oh, I'm not feeling that well today, so let's reschedule this meeting, right? That's a kind of a form of this silence, of kind of kicking the can down the road so that we don't have to deal with it. Versus the other extreme is more of that violence, of kind of that controlling or coercing. So I oftentimes, and I hear this more than anything else in the workplace personally, is when people use absolutes, alls, nothings, nevers, kind of some of that black and white thinking, and that there's never a gray. So we tried it, it was an absolute disaster. Well, yeah, you tried it 5 years ago before we've learned X, Y, and Z and have a new foundation, right? So it's trying to get people to see it your way based on something, you know, that is really very much all or nothing. Additionally, another term that they use is labeling. So labeling those ideas, so to generalize, to get people to kind of rally around and coerce them down your train of thought. So you're not going to listen to them, are you? You know, they're always thinking about themselves. And then attacking. This is just, you know, I can say that honestly, and at Cincinnati Children's, I've seen this very, very few times, so that I can't even think of a specific example. But really just out to win and or make others suffer. So just being really overly direct. I think this has also come up recently in conversations with people who moved to the Midwest from the East Coast, and not hating on the East Coast by any means, but when I first moved to outside of Philadelphia for my residency year, I was like, oh, these are not the kind of conversations around case conferencing that I've had in Indianapolis before. People are very much like, I'm going to tell you exactly what I think. You're going to tell me exactly what you think, and we're all just going to put it out there. Much more direct than even a Midwestern way of going about things. So I think that's also something to keep in mind from a cultural perspective.
Steph, I get that feedback
Yeah.
on every single evaluation I've ever been given, that
Tell
East
me
Coast is
more.
much more direct.
East Coast is more direct. So then they're telling you, we're not used to you being as direct, James. Is that what they're telling you?
Yes.
Yes, right? Exactly. And it's completely cultural. That you take that little piece of cultural feedback and you put it in your pocket and you move right on, right? And you also say, yeah, on the East Coast, they sometimes say water. And that it took me about a month to figure out they were saying water. It's just cultural, no big deal. But yeah, it can cause many, many issues, right? Those cultural differences and variations, even within our own country. Kelly, go ahead.
Jason also brought up autistic people are taught to mask to fit in, and I thought that was a really good point as well.
Absolutely, Jason. Yeah, thank you. Sorry, you went out of my screen, Kelly. So when you put your hand up in the thing, it brought you back up. Thank you.
Yeah,
Thank you for those examples, you guys. This is really helpful.
Sometimes too, because I don't think we think about it in some ways, that some of the disability stuff we're dealing with is cultural, based on other demographics, but then also based on the way that neurobiology or other sort of things work for people, and the way that they receive or perceive feedback. And then that sort of, you know, and so thinking about it sometimes as a cultural thing, or sort of a, you know, either reactive or proactive culture.
Absolutely. I think that's a great point too. And I loved what you said. It's all about receiving feedback and what you do with that feedback. It's sensing, taking it in, looking around like, okay, is this threatening? Is this not threatening? If it's not threatening, I can move on and I can give my feedback. If it's threatening, my feedback may be more of a reaction, right? But it's also the way we were born and bred. So like to James's point, the East Coast, that is the 80%. That is the middle ground, is to do it that way. I felt like it was alerting to me because I wasn't used to it. By the end of my internship, I was used to it and I was fitting right in, right? I was accommodating. I wasn't masking, but I was assimilating to that culture, right? It just was a culture change from what I was used to. And I think vice versa. I was recently talking to someone who just moved from DC, and she was talking about how whenever somebody starts a virtual meeting at like 2 after, they apologize profusely for, you know, oh my gosh, I'm so sorry we're starting late. And she's like, it's 2 minutes after the hour. It's not a big deal. And I was like, yeah, that's just what our culture has become virtually, that you use every minute to every minute prior to COVID, we would always start meetings 5 to 10 minutes late. For those of you who were there back then, you know, we never
Not in
started on
crypt
time.
no, not in crypt time, even with disability stuff. Stuff always starts later just because of access issues and never, sorry, never
Yeah,
disability.
no,
Like we're disability culture.
absolutely. And that's the thing, like knowing who you're working with. And these are things that we want to have managers and leaders take the time to get to know their people when they start a new job. Like it's just such a hard thing right now with COVID. You just can't go get a cup of coffee or get a lunch with your new employee or your new trainee because, you know, you have all these other moral obligations to think about with spreading COVID. But how do you build those relationships so you get to know people and what are their subcultures features, right? What are the things that they've gotten feedback on before, positive, negative, whatever, but just taking that in and not necessarily painting a picture of that person based on that previous feedback, but understanding where they're coming from. And Laura put in the chat box something interesting. I would love, Laura, for you to come off mute and kind of speak more to this as well, because we will have a 3 to 5 session next week on DEI, where we're talking about kind of some racial ethnic differences and some scenarios. So I don't know if you wanted to chime in about what you.
Well, that I have much to say other than it's striking to me that we're talking about all of these areas, but we're not talking about it from a racial standpoint. But it could be that you're planning on doing that next week.
Yes.
And so I was like, oh, it just struck me in my mind that this all like we're talking about in these concepts and we weren't talking in that concept. And that's.
No, thank you for pointing that out. I think it is. It's just we absolutely want to interweave all of the different types of cultural factors into all of our sessions, but we do tend to pull out some specifics on race, ethnicity, disability as a culture, all in specific sessions. But you bring up a good point, absolutely, because you know I always think about my African American or Black patients, how they even feel to get through the door to come see me as a white provider. That's already making them oftentimes feel on the defensive, knowing what healthcare and research has done to their population. So I never take that for granted going into those appointments and knowing how their reactions may be from that place of fear or that sense of mistrust of the institution. So thank you for bringing that point up, Laura. I think when we think about our motives about, you know, reflecting on why we are entering or why we're facilitating or initiating a crucial conversation, or why we are willing to go into a critical conversation with somebody else who's initiated it, we have to think about our motives. And I really want to challenge us all to think about what are the unhealthy motives versus what are the motives of dialogue. And the motives of dialogue go back to those Thomas Kilmann modes. Is it to produce results? Is it to strengthen the relationships? But also is it to learn and find the little t truth, to find that other person's truth, not big T truth, because everybody's perception is different, right? It's little t truth. This is where I want us to live, right? It's like, tell me more. Help me understand. I think I've mentioned this before about one of my most amazing patients of all time. He never says, I don't know. He says, help me know, right? And I say that all the time now too. I'm like, yeah, help me know. Like, I'm not sure. Help me understand your perspectives. Versus this idea of needing to win or be right, look good or save face, avoid conflict. These are the things that we oftentimes, I think, alluded to when we reflected on how we get our way, that we refer to at home, right, with our significant others. I know I do. I know I oftentimes want to win or be right with my husband. It gets to the point where we even like can laugh about it sometimes. I'm like, can we please write that down? That was the day that you said I was right. And this is where we tend to be often with the people we're most close to, but it can seep into our work life, our professional life. And we always just want to remind ourselves, both with our people we're comfortable with and our colleagues, how do we get back to those motives of dialogue? So sharing everything, the how to for staying in the dialogue, even when you're feeling those heavy emotions like anger, fear, feeling hurt. I love this quote. I actually have always loved this quote, and it just goes with all of this so brilliantly, that your thoughts impact your words impact your actions impact your habits become your character. This has always been something that I that resonated with me, and it made sense. And I'm like, no wonder I became a psychologist, right? Thoughts, feelings, behaviors, they all go together. But this I feel like is really important, linking your thoughts with your words, because no one's going to read your mind. And this is what we've talked about with that hidden curriculum as well. Because what happens when you are in fight, flight, or freeze, and I just left this old picture up, but really you go into fight, flight, or freeze, and that's what happens biologically, and it's evolutionary, right? And this picture is not meant to be, perfect, but what I want to illustrate is that where is the blood going? Where is the red going, right? Not to the brain. The brain is not pumping that blood. It's going to your extremities so that you can fight, flight, or stay frozen and stay protected, right? So the last place the blood is pumping is to your brain to help you think clearly. So then what happens when you're feeling angry, hurt, or fearful, right? Your amygdala has been hijacked. And this is what Dan Goleman, the father of emotional intelligence, calls neural hijacking. And it's basically, we don't get a chance to process the input that has scared us, that has angered us, that has hurt us, because we are trying to survive. And it's very natural. And it's kind of that that situation where you might leave a difficult conversation and you're like, man, I wish I would have said this, this, and this, because, oh, you've calmed down, the blood is flowing, you're able to think more clearly, and you're using your frontal lobe versus your visual cortex, your sensory cortex, because you're just trying to stay alive. And so the amygdala is where that fear center is. And so when that gets triggered, all things are out the window. You're in fight, flight, or freeze, whether it's a real physical threat like a snake, a hurricane, whatever, or if it's a physical or a psychological threat. It does nothing different in your body and in your brain. So I wanted to point that out. And I think that Kelly is bringing up something from the chat. Go ahead, Kelly.
Yeah, Jason said, well, no one reads your mind. I think access intimacy is important for all. It is hard to constantly explain every day what you think or to be heard all the time.
Absolutely. And this is what I want us to hear, is that this kind of thing isn't all the time. This is during critical conversations. Yep. When it's most difficult, right? When it's most difficult. So the problem, we have a lack of blood in the brain, and then we're not thinking with our frontal lobe, we're not thinking clearly, and we're definitely not sharing our thoughts, feelings, emotions, and ideas coherently. So our solution is how do we take a step back, create emotions that make us want to stay in dialogue? What can we do to keep safety or to return to safety? That's our main thing. Return to safety, return to safety. So I like to think of it as kind of the good old cognitive behavioral therapist in me. You take in something, you see and hear it, you tell a story, these are your thoughts, you feel an emotion, and then you act on that emotion. And then this goes into a big, nice cycle. And it's what we learn in psychologist school when we first learn about cognitive behavioral therapy is, the scenario is typically what we're taught is, you see a group of people standing across the street, and as you walk by, they start to laugh and giggle. And the story that you tell yourself in your head is, there's something on me. They're laughing at me. I did something silly. They're making fun of me. That makes me feel upset. That makes me feel embarrassed. That makes me feel shameful. I act in a way that hurries up and gets away from them, or I act in a way that calls them out. But it all revolves on this story that we tell ourselves, whether we have evidence for it or not. It's all about the story we tell ourselves. So what we have to do to maintain safety is to differentiate real facts from those stories that we tell ourselves. So for example, I've been hearing a lot lately is assume positive intent. And that's what that is. It's assuming that the story we tell ourselves about somebody being harsh, mean, negative, nasty is incorrect, and trying to challenge ourselves to say, why would somebody do that? Right? That's not fact. That's just the story I'm telling myself. And so the fact might be somebody told a funny joke, or really the fact is they laughed. Okay, that group of people laughed. The story could be somebody told a funny joke, right? And it just so happened that I was walking past, right? How do we challenge those stories that come up in our brains, that impact our feelings and our behaviors, that are a result of our upbringing, that are a result of our relationships? So this can be the most challenging thing. And anybody who's done cognitive behavioral therapy as the patient or as the therapist can attest. Changing your thoughts and the stories you tell yourself, it's hard because they are ingrained as all get out. They are ingrained in us, especially those core beliefs. So things like I'm not good enough, nobody loves me. When those kinds of things start getting into our stories and in our minds, it's really hard to unravel and challenge. So we oftentimes guess each other's motives too quickly, and those stories escalate real fast. Like that person is horrible, I'm the victim, or I'm helpless. And this is what the text talks about as victim, villain, or helpless stories. And I'm just going to breeze through these because they're in your slides, but just thinking through who are maybe the people, and maybe it's yourself that oftentimes gets, identified as the victim or the villain, or how do you feel helpless? So victim is, you're telling yourself it's not my fault. The other person is bad, wrong, dumb, and we're right, good, brilliant. We know these are silly and excessive. But the problem is that we're inadvertently or subconsciously not paying attention to the role that we've played in the scenario, or the role that the dynamic, maybe it's multiple people, maybe it's a team dynamic. And how can we take a stop, get back into safety, and then get going again in a safer way? The villain, somebody is seen as the villain. We're okay. We can rationalize insulting them. And it creates a double standard because we all make mistakes. And I want to say that I am by no means an expert in this, and I fall into these traps myself. This is a lifelong process of always trying to reflect on it and how can I do better? So no one's ever going to master these things and be like, oh, I'm brilliant at crucial conversations. If somebody in an interview for a LEN position says, I'm really good at crucial conversations, I'm like, nope, you're not insightful. No one's good at these things. It's all hard and we're all learning. Or there's the helpless stories. And this is, again, going back to those systems issues or things related to a larger being that we can't even name necessarily. It's, oh, the education system is flawed. There's nothing I can do. I can't help teachers because it's just a disaster right now. Right. And if there's no other option, then our inability to have an action or our unhealthy actions are justified. Right. But the problem is that we don't even take the time to contemplate brainstorming and alternative solutions. And we really need to do that in many cases. So we've talked about the skill number one, which was separating fact from story. We've looked for those three types of stories: victim, villain, and helpless. Then the skills that we'll be working on next week, is telling the rest of the story. And I'm just going to breeze through this, but we're going to spend more time digging in next Tuesday. So telling the rest of the story is answering these questions. What am I pretending not to notice about my role? Why would this reasonable, rational, intelligent, smart person who's working on this project, who works at Cincinnati Children's, who loves healthcare, who's really great, advocate, why would they do this? Well, they wouldn't, right? So we have to change that narrative. And what do I need to do? What should I do right now moving forward to get to my goals? As I mentioned, the problem is that we say things often in the wrong way, and then we have to go back and fix it and clean it up and get back into safety. And I love this quote from the text: there's always a way to be honest without being brutal. And I always think about this when we do feedback with trainees in any way, shape, or form. We want to be honest, but we don't have to be negative Nancy. We don't have to be brutal and make somebody feel like, you know, the world is coming to an end. We just need to give feedback and then figure out how we move on from there, right? And that's what I want you all to do as managers, supervisors, advocates in the future. How do you say, I mean, especially thinking like, how do you say to a family that you're supporting an advocacy, man, you gotta step up and say something, because this is not the way the school should be treating your child, right? That's not brutal, but it's honest. So there's 5 skills that we're going to talk about next week in more depth, but I want to at least introduce them. So it's the what skills and the how skills. And the acronym for them is STATE. So share your facts, tell your story, ask for others' paths, and then the how is talk tentatively and encourage testing. And the how and the what kind of go together, obviously. But STA, share your facts, tell your story, ask for others' paths. And we're going to practice some of those things. So sharing your facts is just differentiating the facts versus your opinions, and taking in and actually telling someone else, what did you see and hear in that scenario? So it's some examples of Kickstarters. I've noticed that, or the last 3 times we've talked about this, or the simple fact of, okay, so the report was supposed to be in by 4 and it's 5. So tell me what's going on, right? Again, honest, not brutal. Then that takes us to telling your story. So sharing the story so the person knows why the facts are a concern to you. And you always want to be checking, okay, am I the victim? Am I being the villain? Am I making the other person out to be the villain? Am I trying, am I helpless and rationalizing in this scenario? I love this one. I'm wondering if, or help me know. It leads me to think, it leads me to wonder. That's it. And then just go from there. And then asking for others' paths. Because remember, we got to get it all into that pulse, because we have to all know what people are thinking, feeling, believing, everyone's ideas, and challenging yourself to let others challenge you. So some example statements could be, how did you see it play out? Or help me to better understand how you saw that situation. What are you thinking about, and what are you feeling after, that patient encounter? So again, whatever context you need to elicit feedback, be genuine with it, right? We don't want to just pretend that we want to hear someone's examples and ideas and thoughts and feelings. We really want to hear them. And if you're not in a place for that, then it's not the time to take on these conversations. So talking tentatively, again, is avoiding absolutes. Never get anywhere with always nevers and all or nothing. But we really want to invite. So maybe our team could consider, maybe we might work on this, right? It's how do we haven't decided yet, because we needed to decide together. And then again, the encouraging testing. And I've just talked about being sincere and genuine, because this builds trust, right? We want to make it safe. So we'll talk about this a little bit more, but again, it goes back to looking for your own emotions. How are you reacting? Is your body getting tense? Most people, when they get tense, their whole core will tighten up. So you will feel it in your torso, you'll feel it in your bum, you'll feel it in your chest. You'll have those physiological responses potentially where you're starting to sweat, or your behaviors are you're leaning in or you're leaning away. So making sure you're aware of how you typically respond. And the best place to practice this and being more aware of that is at home with the people you love. So, what does your body do when you're in those scenarios? And make a mental note of it. Oh, I'm in this scenario and I'm sitting in a meeting at my computer in my office at home. Why am I feeling like this? And so I just want to challenge you this week, looking for those instances of silence and violence in other people, bringing next week some examples to share. Maybe everything is going hunky-dory in your life and you don't see these. That would be lovely. I hardly believe that is going to be the case throughout a whole 7-day period. But looking for those examples and bringing those back next week. And I'll just end with this quote: respect is like air. You don't really notice it until it's not there. Then it's all you notice. So I ended right on time at 2:50, but I'm happy to stick around for questions, but otherwise take your 10 minutes. Anything in the chat box or any other questions? Great. Well, thank you all for participating. Oh, go ahead.
Could you go back to that slide that spelled out the state acronym?
Sure
I
can.
missed the last letter.
Yeah. Encourage testing is probably which that one was. There we go. You see it?
Got it. Thank you.
Yeah, no problem. And Cheryl, I think you were the one that said you couldn't be here next week, but Marta can always share the slides with you as well. Yes, Paul. Marta can share the slides.
Okay. Thank you.
Yeah. Awesome. Well, thank you all for your attention. Len trainees, we'll be back in 9 minutes. And we'll finish this conversation up next Tuesday, but we'll have ITT intros here in about 10 minutes. All right. Thanks, everybody.
How you doing, Steph?
Doing good, I think. How are you?
Good.
I mean, I'm doing this good, if that helps. I'm drinking a soda at 3. So I'm sure I'm gonna go to sleep really well tonight. But it's okay.
It's not Diet Mountain Dew.
It's not Diet Mountain Dew, exactly.
So
Courtney, what do you
there's-
have in yours? Please tell
Why
me.
you
it's
gotta
an
pick on
Oso.
Diet Mountain Dew, Jen? Why you gotta pick
Oh.
on Diet Mountain Dew?
Well, Christy, if you
Yeah.
only knew, girl.
I know, you told me, because I have the bad habit too.
Oh,
Mm.
and I had one last Tuesday night at the Xavier game, whenever that was. Because, you know, I feel safe going now because they make everybody vaccinate and mask. Thank God. They're like the only team ever in this world right now. But I thought it was a bright idea to drink a Diet Mountain Dew, like during the game at like 8 o'clock at night. I didn't go to bed. I watched the entirety of season 2 of Cheer that night in the middle of the night. By the way, it's very good. The whole thing.
If anyone ever sees me with a Diet Mountain Dew, please intervene.
He probably needs some
That's-
psychological support.
That's when you know it's pew, hit rock bottom. Slippery slope.
Slippery slope that Diet Mountain Dew is.
I was gonna say I was just trying to make my bed because I did not make it this morning. And I'm like, that's how I know it's a bad start to the week.
I'm so proud of you. I think I quit making my bed like mid grad school. Oh, that's a
Joyce
real.
is pregnant with COVID. I feel like I'm 8 months pregnant instead of almost 5 right now. So I'm like, hey, the fact that we're all alive and fed, not counting anything is a win
Yeah.
right now.
That's
Exactly.
And I
win.
know
That's
there's
a win.
others that are in the
Huge win.
same thing. I'm like, you're all alive. You're all
Yeah,
as healthy as you can be. That's all I
Yep.
can do.
exactly. I think we're almost all here, right? And I know Marta's dealing with some stuff, so she might be on and off. I don't even know if she's on here right now.
She's
Allie's here at least.
looks like she's getting on.
Okay. And Lindsay's also got some stuff that she may not be able to join the whole time. So
Okay.
I'm gonna make the breakout rooms though. At least I can be helpful that way.
Awesome. Thank you. So I think the main purpose of our time together today is to go over the cases in terms of what we know to this point and the reason for the referral. And so, Abby, do you want to present for T1 first in terms of your kiddo?
Sure. Do you want me to screen share or
Yeah, that'd be great. Thanks.
hang on? That's maybe more skill than I have, but let me see. Okay. Can you guys see this?
Yes.
Yes. Okay, great.
Perfect. Thank you.
And you can
Yes,
hear me?
ma'am.
Yeah. Okay. I'm going to assume you can hear me.
You're great.
So this is our patient for team 1. His name is Jonathan Kennedy. And I can give you guys the MRN afterwards. I'm not allowed to put it on a PowerPoint. So, but going into it, he is a 4-year-old, 1-month-old boy, presenting for kind of trifold reason: outbursts, violent behavior towards his sisters, and anger issues. That is information I actually got from, he was referred in 2020 because of concerns from his mom and from his First Steps evaluator. So he is in First Steps. And then it sounds like the behavior has continued into 2022 now. So that's as much as I know about the referral. There isn't a lot in the chart, so bear with me. But additional concerns that I got, thankfully, from Marta included sleep issues. So he takes 10 milligrams of melatonin, pretty hefty dose for a 4-year-old.
I'm sorry, Abby, really quick. I just realized that there's somebody on that I don't recognize. Jamie, are you there? Is Jamie not one of our Len trainees, but with a different name, right?
It's Jamie Donovan.
Donovan, sorry.
I had
Okay.
to block my phone. Sorry.
You're fine. I was just like, Jamie, not a Len trainee. Yep. Okay, Jamie Donovan. Thank you.
You're welcome.
So additional concerns included sleep issues. So he takes a hefty dose of melatonin. And then also mom reports that no one can watch him because of his behavior. So there may be some concerns about like safe caretaking because of his kind of outbursts and things like that. So that may come up additionally too. When I went through his chart, so this is what I could find, there wasn't much because he hasn't been seen much in our system. But birth history wise, he had a cystic hygroma prenatally, which is like a lymphatic malformation in the neck region. It looks like that might have resolved prior to birth. He was born full term via C-section, secondary to breech positioning. Otherwise, he was, I think, like 8 pounds, 7 ounces when he was born, so a good size, and he passed his hearing screen. So past medical history wise, what I know so far is that he had recurrent episodes of otitis media, so ear infections, and then also tonsillar hypertrophy. And then additionally, he has ADHD. I didn't see that in the chart, but I got that from Marta. And I'm not sure who's taking care of that. I'm guessing his pediatrician. Past surgical history wise, he had PE tubes and a TNA in 2019. Family history wise, I got this from both Marta, but also from his birth record, so things could have changed. But mom has ADHD, anxiety, and bipolar disorder, and then dad also has a diagnosis of ADHD. And then social history wise, I don't know about his parents' situation. I know that mom is involved. I know that he has 3 siblings, an 8-year-old, a 2-year-old, and a 6 to 7 month old, and one of them at least is a sister. I'm not sure if all of them are. And then little things from chart review that I got. This may only be helpful to PT, but he was seen by orthopedics in 2019 for right ankle swelling and hesitancy to bear weight on his right foot. He had x-rays that were unremarkable, and they did recommend external PT for strengthening and follow up in 6 months. I didn't actually see a follow-up, but it looks like maybe he did get PT outside of our system. He was definitely in First Steps because I saw that in the initial eval, and then he was also in Head Start. So, but I think there's a lot of concern about his behavior and how he's going to do in Head Start and school and things like that. And that's all I got. Any questions that you guys have? Stop sharing. And I can give you guys the MRN if you would like. I don't think Steph, I'm probably not allowed to put it in the chat, am I?
Did we do that before? The chat
I don't
gets
think so.
deleted, but the MRN is the medical record
Oh, I'm
number.
sorry.
Jason.
Yeah,
Sorry.
that's how you look him up in Epic. So his name is Jonathan Kennedy, and his MRN, whenever you guys are ready, it's like a group of 40, so I'm gonna think you're ready, is 117-07546. And there isn't a lot in there because he's not really in our system. First Steps, good question. First Steps is EI, early intervention for Kentucky. So he lives in Kentucky.
Hey,
You
Abby,
know where
would
in
you mind?
Kentucky?
Oh, he was, oh, I don't know, Marta might remember better than I do.
Abby, while she's pulling that up, do you mind just reading the MRN one more time? I just want to make sure I have the right one down.
Yeah.
Thank you.
117-07546. And I think Jonathan is spelled differently from the Jonathan that was written in my email from Marta, but
I feel like Jonathan has an extra letter in it.
yeah.
When I'm looking at it, John Austin, J-O-H, Joe Nathan, J-O-H-N-A-T-H-A-N.
So we may need to confirm how his name is spelled.
Yeah.
That's
Mom has not corrected me.
Yeah.
They live in Ghent. I don't know if that's how you say that either. G-H-E-N-T is the city in Kentucky. Carroll County, she said it would be at least an hour and a half to us. And she knows they're all at 8 a.m.
Yeah, it's pronounced Gent, but yeah, it's pretty far down there. you're saying he has outbursts and then
Yeah.
it's towards the younger sister. So is it towards the baby?
I don't know, Marta, did they tell you which, it doesn't specify in the referral.
Towards all children, including the baby.
Towards all of them. Okay.
The baby was 6 months when I first talked to mom, so I feel like the baby should be like 7 months now.
Abby, I thought I read dad may have some legal troubles and possibly incarcerated, but I'm not sure if you saw that.
I think I did see that actually in a 2018 note from neurology, maybe. They
Okay.
had that briefly, and I didn't see it replicated. I think I did see that in one of the notes, and then I didn't see it. We only have like 3 notes to go off of, really, like lots of encounters. So it's possible, but I don't know, Marta, if they mentioned that to you. Thanks.
She didn't mention anything. She just said, we are committed, we will come, but we never talked about who that entails.
Marta, is this the family that we found out about through?
Yes, you sent them to us in the fall. Mhm.
Yeah, so mom is, I actually got contacted by one of our institutions, physician liaisons. And they were basically like, can Cincinnati Children's help this kid? And I'm like, DWP actually can't, but the LEND program maybe can, but they would have to wait till the spring. And mom has been like super interested in this all the way back since like October. So she's really invested, I think, in getting help, and has a pretty decent primary care team that is supporting her.
Abby, you mentioned there were like 3 notes. What specialty areas has he seen?
He's seen ENT for his ear tubes and for his tonsils. He's seen neurology in 2018 for fussiness. He had benign macrocephaly, so just a big head, essentially.
Okay.
And then he saw orthopedics for the right leg hesitancy.
Thank you.
Yeah.
I have a quick question. If it takes an hour and a half to get there for 8 o'clock appointments, is there any thought on how it may impact his performance or his testing?
It's a good question.
Mom was so desperate to get help. She said she doesn't care. She does worry a little bit that they might. So if he's 15 minutes late or something for your eval, I wouldn't be too surprised. But she's so desperate and feels like we're the only people who are going to be able to give her answers because no one around her has been able to help them figure this out. That she doesn't care about the distance or the time.
Also, maybe have some breakfast available from your snack. What's that called? Little kitchenette?
Nutrition center.
Nutrition center. Have a little breakfast.
Those fruit
ready
snacks
for
are
him.
highly nutritious. And
Hey, and
delicious.
Pop-Tarts.
And Pop-Tarts.
There's cereal in there.
And it looks like it could be an hour to an hour and a half for them. So there are ways that, I was trying to figure out directions for how they could come. So at least there's more than one direction for them to come if there's one highway backed up.
90 minutes can be a good nap time in the car too. You never know.
Well, I'm also looking at the fact that he's 4, and he has a 2-year-old and a 6 or 7-month-old sibling. So are the other 2 siblings going to be coming to the appointments? So is there a possibility that mom's going to have all 3 kids?
She did not say. Mom did say she's taken off all of these days and that she normally works. So she might have childcare arranged already. But she didn't say either way.
I would prepare yourselves for having multiple children. However, just based on what I recall, the conversation was that I think mom brings all the kids to the appointment and they see his behavior at the appointment at the pediatrician's office. Actually, I think he sees a nurse practitioner in their area, but I'm pretty sure that's who I talked to. And they do see the aggression in the appointment with the siblings and just the tantrums and whatnot.
So where available, can we consider child life as well and have them just, I don't know who all has it or what days and what times, but just keeping that as a consideration going into this of keeping Child Life aware that this might be a good family that we need additional assistance.
I think that's a great point, Nicoletta. We have had Child Life on our team before in Lend, but since we don't this year, I think it's totally appropriate to request Child Life support just like you would normally in your clinics.
Just out of curiosity, I feel like I have a general idea of what Child Life does, where they just kind of talk to the families and help prepare the kids. But that is just from reading their notes. If someone could give me a explanation of like what they do as Child Life specialists, that would be fantastic.
I'm just going to say, as a parent, when Maddie was in the hospital, they brought games to the room for her to do whatever she wanted. If she wanted a video game, if she wanted a tablet, if she wanted a certain movie to watch. Back then, they were just videotapes. There wasn't, you know, automatically just pick it up on the screen now. Very active, would take them down to the Child Life Center, let them play down there, color, whatever she wanted. They were great.
So we officially only have them at Liberty and at Base, but they can support any appointment. They are very active in the surgical and post-surgical units, pre and post-surgical units, and then in appointments where the child might need some additional supportive distraction. They help out with Botox appointments in PM&R. And I believe they obtain master's degrees. Isn't that correct? In order to be credentialed. So
they obtain a master's degree afterwards. I believe it was 2 years. I'd looked into it before medical school is an option. So more people can jump in, but a lot of times they're well versed on different approaches on how to help children, exactly what you guys have kind of heard already, be it musical, be it physical. And a lot of times just trying to talk families through, or for us, it turns out being distraction in trying to help with those disruptive patients, unfortunately. So I feel like within developmental, we don't get to see the full breadth and benefit, like Sally was kind of mentioned, that you get to see more in the surgical post-operative units. Because a lot of times then they'll use dolls or other tools to help talk the child through, prepare them through, show them what's going on. I know they have different distraction techniques as well for like IV placements and procedures. The funny story I remember is they had one that the kid was a flautist and they were trying to have her blow bubbles and they were wondering why she wasn't blowing bubbles, and it's because she was blowing down instead of straight like you normally would. So they're taught all kinds of different things that you wouldn't necessarily know. I don't know if anyone else can chime in or help, but that's kind of what I know.
We had great experience too. We had it before the tonsil and adenoid surgery for my daughter, and they came in and they showed her, because they were going to put the mask on her, the gas mask. They did it with a stuffed animal, and then they made it as a hat, and then so that way she could kind of play with the item, and then it would feel much more comfortable when it's coming near her face. So I love everything that they do.
So sometimes, so Child Life is physically located in the 3430 location. That's where they have a lot of their services. And so when we know that we have a child who may benefit, you can ask for those services in advance. For audiology, there might be kids who are really concerned when we're making ear mold impressions. Child Life usually has visual stories that they will associate prior to programs and give families picture books of what the family can use to express what's going to happen in an appointment. Oftentimes, our support from Child Life will simply come up to the waiting room and offer big waiting rooms games to play so that siblings are, prepared and that they have something to do while waiting for other kids. And that's, I think, where this kind of conversation came up of, if we have siblings involved, can we have a representative of Child Life, quote, be in a babysitting kind of service for the other children while we're working with that one child. But we do have to request that service in advance if we are looking for that kind of support for the siblings.
And Kim, for OTPT, we can actually put in an order set to request assistance for Child Life. I think my question is whether they will serve in this capacity for like the sibling support. I feel like we've tried to reach out and
No.
request that in the past, and that's been
That-
turned down for that reason.
Correct. They do not provide like childcare support, babysitting support, even of like our patients. So every now and then, for us, sometimes in like a highly sensitive abuse situation, we're able to get Child Life to remove the child so that we can have a more in-depth conversation with a parent, especially if like the parent and I are calling children's services together in the clinic room. But even that can be hard. They're not there, they can't babysit, they can't provide childcare, they have limited capacity. There used to be 3, now we have 2 in DDBP. And they also have this other role of these adaptive care team plans and creating plans for kids who are seen all across the hospital. And so our two do a lot of that work as well outside of their clinic time. So I think that if you think you're going to need support with the patient in the visit, you could ask for that ahead of time from our Child Life team. If you don't know who they are, how to reach out to them, we can help you make some connections.
Can I ask what the difference would be to request Child Life versus behavioral support? Like when you would use one or the other?
Like the behavior support team, the
Yeah.
BST. So Child Life is a part of the BST. So there are Child Life specialists in the BST, in the behavior support team. The BST is just coming to ambulatory. They've been really just inpatient. So that's been a piece of it. Was BST was inpatient, Child Life was outpatient. Now it is possible for an outpatient visits, children being seen outpatient, to have a BST that includes some Child Life support, but if it depends on what the support is needed. The BST plan will say who provides what level of service. So is it a mental health specialist who's accompanying, or a behavioral health specialist, is it Joe and them accompanying the child into the room? Or that might be named a Child Life specialist. But the plan should indicate who the people are who can do each of the services, each of those interventions in the BST plan. And then an ACT plan is found in the same place of EPIC. So if you know where to find a BST plan in EPIC, then you know where to find an ACT plan.
Okay.
Kelly, I can also show you later, but we have a job aid that goes through the order set for all 3 of those things for us. It kind of helps with the decision making between the 3 of those as well, between the ACT plan, the BST, and the Child Life.
Got it. I was going to say I requested BST based off someone guiding me through that, so I was just curious what the other ones were.
And it sounds like for this kid, BST is definitely appropriate.
Do they
Now,
bill?
what I was going to say was, what I noticed is when Grace is inpatient, we have BST services. But if we're just going to a doctor's visit, then we have Child Life services. She is on the ACT plan, so whatever we there, somebody is there to support us. But usually BST was more of an inpatient thing for us. Or if she was having a procedure, they would be there. But if we're just going to the dentist or something like that, Child Life always comes for her.
And we're hopeful that we can get BST and outpatient visits as well over time, hopefully.
That's all I got. I don't know if anyone else has any other questions. You guys have had really good questions so far.
Yeah, really good discussion, guys, and led to a broader discussion about what some additional supports are throughout the hospital. All right.
The only thing I'll add really quick is if we are worried about aggression, making sure that you check in with your supervisors or whoever about any kind of personal protective equipment. So any kind of sleeves or, I mean, obviously everyone's masked and goggled anyway for spitting, but just making sure we're all protected.
So
you don't
along
want to have
those
to call
lines-
803 safe and wait on hold for an hour just to tell them
Along
we got
those lines, Stephanie, so like in our division, if an occupational therapist saw a child, there's a whole screening they would do that asks very specific questions about whether there's an elopement risk, whether there's a biting, scratching, hitting, or throwing risk. And then it populates a field that reminds us what PPE to wear for protection. I'm wondering in this case, if it would be helpful to go ahead and establish an ACT plan, to ask Child Life to call the family and ask what helps this child manage appointments better, what we can have as a support. This might be a kid who doesn't wait well in a waiting room, and we need to be ready to go right when they get there. We might find out that scratching, hitting are frequent, and then we would all know what we need to wait, and then we should share that with everyone. That would be my my plan. Thanks, Lindsay.
Do you need me to reach out to child? Like, I'm down in clinic all the time, so I could just stop and ask and tell them a heads up. I just need to know. I think I can find the dates of the first evaluation, but I can talk to Child Life tomorrow about it.
I think it's next week. And it looks like it's with Lindsay Mays and the psychologists. And so Lindsay's actually offering to ask those questions and then share with the group rather than doing an official ACT plan with Child Life. And then that the psychologist can share with us. How do you guys feel about that? So
I think it would be nice to have the ACT plan in the system so that everyone has access to it in the medical record where they're used to seeing it personally. But
I also think that would be helpful for our trainees to see the plan in place, what it looks like in the medical record. And Abby, if you are reaching out to the family, you know, we all know that things happen and sometimes siblings need to come along, but if we can have that reminder, if childcare is available, it makes a big difference in the parent being able to support the individual child and not have to direct their attention away. So if you know, knowing that there are other siblings, if we can make that reminder, if at all possible, not to have our siblings accompany.
Okay, I can ask Child Life then and see if they would be able to reach out to the family before next week and set up an ACT plan.
all right, very good. All right, so that's for team one. Andrea, are you ready to present for team two?
Yes.
Perfect.
One second. I'm trying to see how to share my screen. I forgot. Oh, it's there. Here's the green button. Can you guys see my screen? Okay.
Yes.
So this is our second case. Our hero name is Cooper. And we don't know much about him, so I kind of grabbed everything from the chart. He's a 4-year-old Caucasian male, and the main reason that he was referred to us is because of the family concerns for autism. I talked to Lindsay, and one other thing that I didn't include here is that he is actually, his father, I believe, works for Cincinnati Children's, and his sister has a history of autism, the older sibling. So what I was able to gather from his chart, a little bit about the prenatal history, uncomplicated pregnancy, mother received complete prenatal care. Mom had a history of obesity and asthma. About his birth history, he was a preterm delivery at 36 weeks, C-section, no further complications during delivery. He did not require a NICU or special nursery care, and he was discharged post-delivery 4 days. Then regarding the family history, couldn't find anything about his dad on the chart, but the mother, as I said before, had obesity and asthma. Older sibling, a female with a speech delay and autism spectrum disorder. Personal history, eczema, and a recurrent otitis media. He actually got surgery, so he got ear tubes in 2019. And that was basically it. Then he is followed by a pediatrician, and the parents have been the different case from last time, in which we didn't have access to the chart, but I was actually able to see all the visits that the father or mom took him to, and he went to all of the well child checks. And when I went over every milestone that usually the templates of the provider have, that they are recording if there is any delay on them, and all of them have been normal. At the 15 well child check, there is the option for an MCHAT, but it said not provided. I went to the scan documents too, and I couldn't find anything. So I don't have an MCHAT for him. And for the people, I think maybe the majority of us know what the MCHAT is, but the MCHAT is just a tool that it helps us with questions regarding screening for autism spectrum disorder. And they ask about parents, about speech, about interacting with others. And that wasn't there. And then regarding the growth, his weight always ranging between 60 and 90 percentile. The length was 90%, and the head circumference was also normal too. And a couple questions that were raised for me when I was reviewing this chart. He got a request. There was a request for allergy and immunology in 2019, I think, because he was having problems with not being able to tolerate some foods, so food sensitivity. I don't think he followed up with that. I couldn't see a note from the specialist. He did follow up with the ear tubes. He had them bilaterally. And from the primary care doctor, pediatrician, I did not see any concerns, except that it says message from family requesting a psychology evaluation on October of last year for consensus behavior problem and a speech delay. And that was it. I did not find anything else for him. And like I said, when I was reviewing every chart for the developmental milestones, I did not see any concerns from the provider about that. And I didn't find an MCHAT on file. All his labs, like hemoglobins, and lead, and all of that was done at 1 year old, and everything has been normal since. That's all I have. And then I was trying to remember what 4 years old do, and I thought this was nice. But do you guys have any questions for me?
I had a question. It supported that he was discharged after 4 days with no other notes about his delivery. That seems like a longer time to be in hospital with mom. There might not have been any notes to support why he, typically it would be 24, if not maybe 48-hour stay, not like right now, in and out, you're out of there. But 4 days does seem a little bit longer than normal to be staying in the hospital for a typical delivery.
Yeah, I thought it was because his weight and breastfeeding. I saw the weight kind of decreasing, and she saw breastfeeding specialists a couple of times when she was in the hospital. They ended up not breastfeeding and ended up going with formula, and his bilirubin was a little bit high too. Didn't require lights or anything like that, but I think that was why.
That makes a lot of sense. Thank you.
Yeah, thank you.
Andrea, I didn't catch this patient's name. Could you repeat that one more time?
Yeah, it's Cooper. I forgot his last name. 1 second. have it here. Yes, it's Cooper Bauti. I don't know if that's how you pronounce that. Is that B-A-U-T-E? And if our team is interested in the MRN, if you guys don't know it, is 11-68-6938. Date of birth 9/5/17.
James, can you provide some more information about what you found regarding the Vanderbilt? And I don't know what the CBCL is.
Sure. So the CBCL is kind of a broad measure, kind of screener, or more broadly a measure of all different types of behavioral and emotional difficulties that kids can have, and then groups scores based off either DSM disorders and also just across general kind of scales of behavioral things like emotional reactivity, attention difficulties, aggressive behavior difficulties, mood difficulties, all those types of things. And then the Vanderbilt is a measure of ADHD symptoms and ODD symptoms, and then some kind of quick questions about anxiety and conduct disorder type symptoms. So I have teacher pulled up now. So teacher had reported 7 inattention symptoms of ADHD and 9 symptoms of hyperactivity, impulsivity. And the threshold for an ADHD diagnosis is 6 symptoms in either one or both of those categories. And then mom had reported 5 symptoms of inattention and I think 7 symptoms of hyperactivity, impulsivity. Yeah, 5 and 7. Yep. And then mom had reported 6 symptoms of oppositional defiant disorder, and teacher had reported 3. And then both had minimal anxiety concerns. And then on the CB,
go ahead.
Go ahead. I was going to say on the CBCL, that more broad measure looking across those different kind of diagnostic categories. The things that were jumping out were high rates of emotional reactivity, attention difficulties, and aggressive behavior. But the aggressive behavior is more so like emotional reactivity and impulse difficulty. So being really demanding or getting easily frustrated, having temper tantrums, being impulsive, those types of things.
That's really helpful. When was that done? That was at a pediatrician's office? Or with
So that was for his BMCP eval they completed. And it was completed in December of 2021. So I don't know if they're still awaiting their BMCP evaluation, but it's part of the pre-visit screening that they do.
We were just noticing that they're scheduled to go see the Center for ADHD in the beginning, right before our ISS. So we will figure that out as we go. Because if BMCP is a better place for him, I'd hate to cancel visits and have him then back on a wait list for something that would be a good fit for him. So we can kind of work messaging the psychologist that he's scheduled to see. And then James, you're on this team, right? So we'll just be careful about not replicating things and making them do more paperwork than they need to do.
I might have missed this, but what were the behavior concerns that indicated this referral? Were there specific behaviors noted?
I couldn't find a note regarding like the physician. I don't know if anyone else did, but on the diagnosis that a provider can place, there were a couple of them. Let me see. Where did I put these?
I mean, the referral just says behavior problem in childhood, disruptive behavior.
Yeah,
and that's it.
disruptive behavior and a speech delay, but there was nothing specific.
Any other questions about Connor? Is that the right name?
Cooper.
Cooper, sorry. Cooper. I wanted to backtrack just a second to team one. So this is probably jumping a little bit ahead, but wondered from our like psychology and developmental pediatrician standpoint, mom in that case has a diagnosis of bipolar disorder. I wondered if you all could share, if someone could share with the group what bipolar disorder would look like in a young child and when that could potentially be diagnosed. I'm just curious.
I don't think I'm going to be able to answer this as specifically as I
I was going to
could.
say that is a loaded question, Dr. Brown.
So I wouldn't expect to see some of the symptoms that we would use to diagnose that in the DSM with an adult until later, maybe more around adolescence, but maybe just looking for emotion dysregulation in general, low mood, and sort of that piece of maybe irritability. But I don't think that we would really see manic episodes that young, and I don't know if someone else can jump in on that. I would think it would be hard to pull apart from hyperactivity at his age.
Yeah, I mean, so technically for bipolar, you have to have episodes, like cyclic episodes. So I have never seen a 4-year-old that would be diagnosed with bipolar. And I feel like the earliest I've ever seen it in the clinical setting is like in teenagehood at the earliest, just because you need like discrete episodes of both depression and then like also mania or hypomania. So you need like discrete episodes, which is monitored over time, which is why I think we probably wouldn't see it. But I agree with Kate that it would probably present as kind of mood lability and more behavioral disturbance. But I think no one would probably diagnose it that young, and they would monitor. But it's definitely something to always think about because of the familial link in bipolar.
In previous training, I've been told that it's really rare to see bipolar onset so young without the hypersexuality component of it. And often that is like the thing that keys you into thinking of bipolar disorder when you're talking about kids who are that young.
Very
I would echo all of that. I would just say that for me, bipolar disorder is always in the ballpark with reactive attachment disorder, that it's way overdiagnosed by people who shouldn't be diagnosing it and don't have the knowledge and experience to touch it. So, yeah.
Good to know. All right. Any other
However,
questions?
I do, sorry, I want to take that to another step too, because I do think that there is something to be said, not just for the familial aspect of a diagnosis like bipolar disorder, but just the environmental. So when mom is in a depressed state, like that is going to impact the child's behavior as well. And so we, maybe we even want to gauge, how she feels that her diagnosis is being currently managed and if it's typical of what she sees at home and those kinds of things. Because if she's depressed, he may be depressed, or if she's depressed, maybe he's more hyperactive because he's trying to get her attention. Or if she's manic, maybe he's mimicking some of those symptoms. So I think that there's just a lot of, maybe even some literature we could explore around bipolar disorder in parents and the impacts on kids. If that comes up. But if she's well managed, then yay, that's great, right? If she feels like she's getting the supports and medication and therapies that she needs, that's the ideal.
I just had a question also for team one. With the outbursts and his violent behavior, has he always had this, or is this something that started after little sister came into, after being born, or is it something that maybe if dad's in and out of the picture, is it something that started then? Do we know any history on that?
The only thing I could see is that they listed those concerns in 2020 when they made the initial referral. So it's longer than the youngest sibling, at least. but I don't know if it's been his whole life. And in 2020, he would have been closer to 2 years old. So that's assuming that early developmental stage at least.
Great question. And I really appreciate the further information about bipolar disorder in childhood, but also especially, you know, what Steph is bringing up about his environmental experiences with mom experiencing bipolar disorder. Any other things? Do you guys feel comfortable with the schedule for evaluations? I know, and Marta's already spoken a little bit about how this semester could be a bit trickier with the COVID ramp up right now. And also we always have a little bit of a harder time in the winter with weather conditions. So we can sometimes see cancellations for that reason. But Marta, do you want to speak to that any further?
So I've reached out to all the clinical supervisors to see if we have a game plan, if we need to reschedule for any reason. So it's snowing, kids are sick, trainees sick, supervisors sick, and just trying to think ahead and just work ahead, plan ahead, because it makes my life a little less stressful and brings down my own anxiety when I have some sort of a game plan. So a lot of your supervisors have given me some feedback if they have protected time, when that time is. And so we might be doing some jumbling around. Hopefully everyone is healthy and it doesn't snow on a Tuesday morning. It just never happens that way. It always snows on a Tuesday morning, especially poor Team 1's family who's traveling from very far. So even if like it doesn't snow much here, they might have a very different weather system. So stay in touch. However you stay in touch with your supervisor is fine. If there's, I will probably use email for last minute cancellation reschedule things, because I might be doing those from home as well, or your supervisors and I might be texting. If you would prefer something that's not email, let me know and I will try really, really hard, but check your children's emails the night before and the morning of your eval.
Yeah, and I would say we will try to make announcements on Canvas, but we can't guarantee it. The only thing we can guarantee is that Marta will email your children's email.
Anything else we should cover? Or is it time to head to breakout rooms? You guys good with breakout rooms? So you may or may not have things to talk about today, but if you do, you are welcome to go to your breakout room.
Oh, sorry, I had them built and you were supposed to be able to create them. Can you see them or not? Oh yeah, they are still there. Woo! All right, first win without Anna. We can do this. We can do this.
All good. All right. See you guys next week. Some of you.
Okay, I'm a little confused. Am I supposed to be here or not? I never got a breakout room option.
I did it so that you could select. So if you go to breakout rooms, you can choose non-patient facing. So everybody can choose the one they want to go into.
Gotcha. Thank you.
Mm-hmm. And Andrea, I think Pam's not here today. So you feel like you're good?
Yeah, I'm good today. I'm just, we need to find out about, I didn't realize it, when Lindsay was mentioning this stuff about the ADHD.
The ADHD center, yeah.
Yeah, I don't think the meetings are at the same time I was going through them. Like some of them, I have it open here. the ones that he's gonna have, I think they are gonna be later in April, and I don't think none of them intervene, but
I
should
just,
I be doing
with,
something?
with psychology in general, we wouldn't be able to do the same things that they're doing. So I
Okay.
think that she and James can just talk, and you
Okay.
and Pam, and she and James can connect, and figure out what instruments to use and things like that, so that they don't duplicate services, because that's the biggest
Okay.
thing, duplicate services.
Okay, all right, and then I'll
Right,
just,
but- Yeah,
okay.
Lindsay can
I'll just-
probably help out with that. Just check in with Lindsay Mays and James.
Okay, I'll do that, and then I'll wait for Dr. Williams to give me more direction then.
Okay, sounds good.
Thank you, sir.
See ya.
Hey, Steph, I can't join the breakout room for some reason. I don't know. I've
Oh,
never had
weird.
that problem before, but I'm
Let
on a
me-
different computer.
Hold on.
so take your
Okay,
time.
let me put you in OT then.
All right, thanks.
Hey, Nicoletta, are you having trouble?
I was just trying to join in. My son just had a blowout diaper. So where are
Oh
we going?
gosh,
I'm sorry.
you're fine. You guys, since Pam's not here, you don't have to. I'll put you in there because Elodie and Abby are in there, but you guys can head out.
We can
too.
head out from there. And that's what I
Yeah.
thought I heard you say. And
Yeah.
I wasn't sure because I was in the corner
Yeah.
like, I hear the guys and I have
No,
no
you're
clue.
fine. I hope he's okay. Oh my gosh.
It started yesterday for him. So
Ugh.
we shall see. But thank you.
Yeah.
I appreciate
Yeah, no
it.
problem. Take
Thank you for your
care.
support.
Stay safe. Stay hydrated. If nothing else, stay hydrated.
Oh, exactly. Thank you.
Yeah. Yeah, no problem. Take care. Vicky, I think we're good. I can hang out until everybody's off, and then I'm gonna cancel, or I'll turn off the recording now though. Stop